Good morning. Thank you for the introduction. And Joanne and Osama, thank you for the great work. And obviously, I have to thank David for the tremendous endorsement that he gave me earlier. I am fortunate to be able to work in an environment in which I work with a friend who is my boss, the chairman of neurosurgery at Lenox Hill Hospital, who is also a mentor and a sponsor. And he's extremely fortunate to be in that situation, but it's important that I do try to tell you guys that if you have an opportunity to work in an environment like that, take it, because it is the best decision you'll make in your professional life. To be able to go to work on daily basis with someone that supports you and that you support and that respects you and that you respect 100% of the time. So again, thank you, David, for the kindness. So I'm gonna show a case, and we're gonna make it short since it's a 2-hour procedure that we need to summarize in 5 minutes. This is, let me see. 61-year-old man, history of hypertension, and presents with acute right hemiplegia and a left putaminal hemorrhage. So typical presentation for an intracerebral hemorrhage secondary to hypertension. In many places, this patient would just get a plain CT and done and manage hypertension. But obviously, he had some findings on a CTA that led to the entire workup. This is the equipment that we use for the procedure, a 6 French long sheath. The guy has atherosclerotic disease, so I went from the get-go with a long sheath. Use a benchmark catheter and we use glue for embolization, so we use Magic. We did 2 separate glue injections for this AVM, and I'll show you now. So that's the CAT scan. As I said before, many places in the setting of hypertension, this would be a plain CT and controlled hypertension. But you see the CTA did show some features that were suspicious for an arteriovenous malformation, and specifically a possible aneurysm. This is the angiogram, AP lateral view. And here you can see that there is a very small arteriovenous malformation, nidus, that has supply from lateral lenticular striates as well as the anterior choroidal artery, and we will be able to see that better as we do superselective injections. There's also what appears to be a flow-related aneurysm as well as an aneurysm on the venous side. And I'll show that better with the microcatheter injections. So again, we advance the benchmark catheter as high as possible in a safe way. You can see that it's all the way up to the cavernous petrous portion of the carotid. I do not use a DAC or intermediate catheter for these procedures because it limits the mobility of the Magic microcatheter. Here, we navigated the Magic into a lateral lenticular striate. We see the region of arteriovenous shunting. I'm going to show you another picture now because the top portion of the picture is cut in this image as we need to maintain privacy for the patient when we record these pictures. Now you see a better centering, and there's a flow-related aneurysm. I see stagnation of contrast. It's more like a pseudoaneurysm, and this is most likely the source of hemorrhage, given the characteristics that we're seeing in the angio. Again, another injection after we were able to advance the catheter a little bit further, and you see again the contrast stagnation in what appears to be a pseudoaneurysm. Now you don't see the pseudoaneurysm in this picture because look at the contrast stagnation. So that appears to be the unstable weakness in the angioarchitecture. We're getting ready to do the glue injection. You're gonna see, I don't know how many of you use glue Obviously, Professor Piotan demonstrated a masterful way of doing it. But here we're infusing the D5W. Someone spoke on my left. I needed to concentrate. You saw me saying, "Someone stay quiet." And now that I'm infusing the D5W, the dextrose, and we're getting ready for the glue. You saw it was a mixture of 1 cc of NBCA with 2 milliliters of ethiodol, 1 gram of tantalum. You can see it here, sitting on the table. Now, my physician assistant is giving me the glue. Physician assistant, we always work with PA that works with us on every case. And this is a live glue injection. He's going to be the one pulling the catheter when I ask him to pull. Glue penetrated very nicely into the feeder, into a region of arteriovenous shunting, pull the catheter, no significant reflux. Important to mention, when we see an acute case, one of the options is waiting for the patient to recover clinically before taking the patient to treatment. However, because of the apparent instability of the weakness in the angioarchitecture, we decided to proceed with treatment at the same time of the angiogram. Important to mention also that super selective injections with a microcatheter make a big difference for us to understand the AVM better than just doing a global injection from the carotid. After the first embolization, you see that there's still residual, and the residual is now from the anterior choroidal artery. Look at the beautiful picture showing the choroidal blush as well as the area of arteriovenous shunting. We're going to navigate further into the choroidal to be able to get to the area of fistulization. And now we are in good position. We had to go back and forth multiple times to be able to demonstrate that we were in a safe position for embolization. But this appears to be a very safe position for us to inject. And now we're going to prepare the glue. Here, and I'm showing this for people that don't do glue frequently. I always do the same thing. It's always the same setup. Always, and this I learned from Professor Bernstein during training, and I continue to have exactly the same setup of 2 1 cc syringes for dextrose, 1 3 cc syringe for dextrose that we're going to use to irrigate the microcatheter before injecting the embolic material. And we have the setup here. I kept the glue in that we had prepared before inside a syringe to minimize the exposure to air. And now when we're getting ready to inject for a second time, now is when I put it in the beaker and mixed it again, getting the dextrose into my syringes. Always make sure that there's no contact with any of the other syringes with saline or contrast on your table. So we always have use towels to be able to separate and have a different working position to prepare the glue. Now we're drawing the glue. We use a little needle at the tip of the syringe to make sure that there are no impurities or no solidification or of the glue gets into the syringe. And we inject with a 1 cc syringe. I know people have different techniques, and we use continuous column. I know that some people like to do pushes with dextrose. So now, for some reason, the camera stayed behind. So now we're gonna get ready. I give the glue to my assistant, and now we're ready here. Let's looking on top. Actually, that was the glue injection. You saw the microcatheter coming out. Glue penetrated very well. we're gonna do another angiogram that shows minimal residual, but there's minimal residual from a lateral lenticular striate. We struggled for a little bit to try to advance the microcatheter again for a third glue injection into that lenticular striate. But it was very tortuous, and we couldn't get to a safe position. And we decided that since we had eliminated the abnormality, the aneurysm, to wait and look at this. The follow-up angiogram 3 months later shows that it's completely cured. That even that little residual went away completely. So by slowing the flow and some amount of glue in the region of arteriovenous shunting was enough to cure. I don't know if you guys have any opinions, any criticisms. And I imagine we're going to talk about this a little bit later after everybody finishes. But thank you. Yes, Dr. Pitan. Okay.
I will have a concern about the 1 cc syringe.
Yes.
Very practical, because it's a magic 1.2.
1.2 FM.
In the IFU, it's totally clearly written that do not use syringe under 2.5 milliliter of volume.
Okay.
In my department, there was an issue, only an issue about 1 cc and rupture the catheter. In France, there was an issue in other France with legal consequence. And the doctor and the hospital are lost because in the IFU is 2.5 minimal volume. Because the pressure you put with 1 cc syringe is tremendous, and you can have a risk approach. That's all.
Okay. Anybody else has had that issue?
I changed because someone told me that. I stopped using 1 cc's. But I think the key thing for me is if I'm using a 3 cc syringe injected glue, that's also what I use for the D5. So it feels the same before. So same flow conditions.
Okay. Yes.
For the first injection, Francisco.
Hi.
For the first injection, through the I will try to navigate further because you were in the middle of the
Yes.
and there was a high risk region which will have some instance complication.
Correct.
As we had a hemorrhage, we do not have any problem.
We did attempt to catheterize even more distally. We tried to go as close as possible to the fistula site. However, it was, as I said, we summarized this in 5 minutes. It was a struggle to try to navigate even to that point. So trying to go even more distally was becoming unsafe with an unstable aneurysm. So we had to go ahead and cure, but I would have preferred to go more distally, yes. Yeah.
You mentioned you're trying to avoid distal access catheters
Yes, for Magic.
for Magic
Yes,
specifically.
yes. Because we want the
You have more stability, like you're saying you had problems navigating. You have distal access catheters provided to eliminate redundancy.
the problem was more at the distal level of navigating inside the lenticular striate. Inside the lenticular striate. Okay. Thank you so much.
Okay.